Thank you. Well, first of all, what I like to do is understand who I'm talking with. And so I would like to, I know that most of the audience attendees are healthcare professionals. So can I get a show of hands on who are physical therapists? Great. And then occupational therapists? Oh, good. Awesome. Awesome. Speech therapists? Okay. And then nurse practitioners? Physician assistants? Physicians? Perfect. And I know there's a few patients and from the community. Who's from the community and patients? Perfect. And anything that I missed? So I'm sorry, yes. Registered nurse.
Social workers.
Social workers, thank you.
Activity therapy.
Thank you. I knew I'd missed, I'm so sorry. And what? Yes, thank you, thank you. So this is great because the diversity is significant. So again, just a little bit of correction. So I'm a licensed physical therapist by trade, and that's been for 18 years. And for those 18 years, I've been working with the Rocky Mountain MS Center for about 17 and a half of those. So very clear to 18 years. I've been working with one of the co-directors of the Rocky Mountain MS Center, Dr. John Corboy, and we used to do co-treating together back when we could do that and charge for that. So I've learned a lot from him, and I think he's learned a lot from me, and that's why I want to bring this as far as rehabilitation and the importance of MS rehabilitation. But at the same time, when I say rehabilitation, I also want to think about us trying to change the paradigm of rehabilitation and changing this to be a little bit more proactive, not a little bit more, a lot more proactive. And rehabilitation, a lot of times, the connotation there is to wait for something bad to happen and try to reverse that bad. What I'd like to see is everything that I bring up today and beyond is that we think about being ahead of the curve, ahead of the disability curve, trying to treat with our expertise in rehabilitation, but also in exercise physiology, and the ability to prevent advancement of disability. Because I feel very fortunate working with an MS center where we have 3,000 every year distinct patients with MS that we see. We have upwards of 500 new diagnoses every year come through our clinics. So I have a vast amount of obviously knowledge of persons with MS, but the experience to work with practitioners, frontline providers that are prescribing the medications, but a very close second is going to be how does physical activity, exercise, and some of the things that I bring up today is a very close second to make sure that we're preventing disability advancement in persons with MS. So I'm the director of the Balanced Performance Lab at the university and the director of rehabilitation and human performance research for the MS Center specifically. I don't have any disclosures specifically for this talk, but I do have to recognize that or state that I'm a grantee of two of my research projects right now, a grantee of the National MS Society, and also one of my other projects is a grantee of the the NIH. So other than that, I have no real disclosures. The objectives, I have to list these pretty much for your credit for attending, is the specific objectives of today's talk. But the overall concept is I'm really going to focus in on areas that I have been doing research and the knowledge translation of that for you as practitioners. So the key word is evidence-based, because we can hyphenate that, so evidence-based practice. But it's also knowledge translation, and what we know about that is that clinicians benefit from, yes, obviously the written word on the research article is helpful, but it's also nice to learn about the background and the conceptual framework, what went into discovering some of these things that I'm going to talk about. So the overall objective, when we take these bullet points and we throw it at you, is that I want you to have knowledge of the background of what you might read in some of my research. And if you haven't had the ability to see my research in print, if you don't have the access to PubMed or Medline, I'd be more than happy to share that with you if anybody would want that. And Vicki can let me know of anybody that needs that, so I can send those over to you. Specific talking points is that we will focus on balance, we will focus on gait abnormalities, and the complexity of that, multifactorial. I'm going to give you a piece of the pie in 3 different areas of my research and how that can translate right now into your clinical practices as much as possible. The focus is going to be on what I've termed the balance as a function of central sensory integration. Bless you. So that I will say that it is a complex process, but I'm going to try to simplify it as much as possible. Translating that research into practice, bringing you, again, the background of an innovative design of an approach to not only improving balance, but other clinical manifestations that are related to postural instability, especially in persons with MS, including fatigue, dizziness, and other conditions. And then some of my early research on muscle and brain function and focus on walking. So everything's going to be focused on mobility, walking, and postural control today. Because there's a lot of, because I do 1-day, 2-day courses, and that encompasses all of exercise and all of walking and all of postural control. But I'm really having to focus this into the talk today on balance control and the interventions specific for that. So the walking, obviously, is something that when we talk about disability in MS, it's heavily weighted on the ability to walk, the ability to obviously then prevent the advancement of ambulation impairment. And obviously, it's very important for persons with MS. It's the top of the pyramid. All these other factors, as you know, a person with MS from head to toe can have every possible complaint or symptom, and that's what's very interesting as clinicians, as researchers, is that you have a laundry list. And I'm going to be talking about specific areas that along this laundry list is very focused in, knowing that there's other complaints that fall into there. And walking, regardless of diagnoses and duration of disease, is something that patients with MS hold high regards. Obviously, it's very prominent, but then also for caregivers and care partners, it's also something that we have to take in consideration, that it also affects other people that are involved in patients with MS in their lives. So obviously, that's a key component. One of my PhD students designed this, so I've given him credit because we also do some talks together, is that he designed this kind of like almost flow diagram, because it all flows into the components that make up abnormal gait in patients with MS. And that's multifactorial, I would say. So I can't hit on each one of these, but there's obviously a disclaimer today is that, yes, it's multifactorial. I cannot, well, number one, right now, study all these components. So I'm honing in on my research on very specific areas. And then also clinically, we have to understand that we have primary contributors, and then we have the sequelae that obviously feeds into that. Fear of falling is something that we register maybe through the ABC, the Activities of Balance Confidence. And just the fact of fear of falling in and of itself can be a leading factor of falls in MS. So today we're going to focus on 3 components, and I'm going to start here with balance and related postural control. Even balance has multi-factor components to it as well. And within this whole realm of balance, and Faye Horak out of Oregon came up with this kind of like diagram. And then more specifically today, we are going to focus on sensory organization. It's a really area that actually was the impetus for me to go. I built the cases in the clinic, clinical case studies and reports. It was the impetus for me to get my PhD to study this very thing for my dissertation. And then it now has flowed into continued research. In the sensory integration, I will focus in on. So it started with, you know, balance, fatigue, dizziness. You know, it's very prominent. In patients with MS, it's upwards of almost 90% of patients with MS have some component of instability. The etiology of that, of course, is multifactorial, and I will focus on the impaired central sensory integration of that component. Falls, greater than 70% of patients with MS will eventually have falls. Recurrent falls are common, and obviously starts to lead into more advanced disability if it's uncorrected, the fall risk overall. And again, even fear of falling. And then, like I said, there's early evidence of how it's related to integration of the sensory systems. I do have to make sure that we have a very good understanding of the dichotomous definitions of fatigue. So many times in MS, we think about it as that lethargy, as that symptomatic fatigue. But an area of fatigue as well is performance fatigability. I will start the talk today with symptomatic fatigue as being our primary. One of my colleagues at University of Colorado, Dr. Kluger, and then up in Boulder, Dr. Roger Inyoka did a fantastic white paper on symptomatic fatigue versus performance fatigue. And I urge you to read that white paper and an expert review on the differences between symptomatic fatigue and performance fatigue. Symptomatic fatigue is that complaint. So it's the perception of fatigue by patients with MS. And as you know, it's one of the biggest symptoms that we come across in patients with MS. But impaired imbalance plus symptomatic fatigue has been found to be a major contributing factors, X factors, to leading to more progressive, poorer quality of life in patients with MS. So prior to my research, it was found that there was no relationship between some very, very small studies and very limited studies on the concept of symptomatic fatigue and postural instability. And it was very mixed, and there was no relationship found. However, what I was deciding was that I don't think they're taken to the next level. Number one, they weren't using the right measures. None of them used the modified fatigue impact scale. Now I know that we all probably have our favorite measures of symptomatic fatigue, and it might not be the MFIS. So I apologize for those that disagree with me, and we can have a talk after. No, I'm just kidding. So in one of my studies, I had the review, one of my reports, the reviewer said, can you explain why you use the MFIS? So you can read that in the discussion in one of my papers. So I think I had a pretty good argument for why to use it versus some of the other ones. So then combining best measures of symptomatic fatigue in MS with the best measures for postural control. So dynamic posturography is what we have, what we did in this study. So Dr. Corboy and I did a pilot study on the association between dynamic posturography stability and symptomatic fatigue in patients with MS, published in 2013. Who's familiar with dynamic posturography sensory organization tests utilizing the neurocom system? So I saw one hand. Okay, perfect, excellent. So, not perfect that there was only one, but so this is going to be educational. So there's 6 conditions. So this is the dynamic stability. Prior research stopped pretty much at conditions 1 and 2, which are static posturography, which is what we do in the clinic. It's maybe slightly less than the Romberg and sharpened Romberg, which is a Romberg, feet together, eyes open and eyes closed. That's good for really quick clinical assessment, but when we're starting to really tease out just how well a person with MS, and anyone really, is able to utilize their sensory systems, so vision, somatosensory, and vestibular systems, we are then able to bring, with my technology, utilizing the neurocom system of conditions 3, 4, 5, and 6, we start to now tease out, are patients more visually dependent, somatosensory dependent, and are they able to utilize their vestibular system, their inner ears, for upright postural control? Now, are we able to diagnose unilateral, bilateral vestibular loss? No, we're not doing that. But it's the performance of upright postural control and being able to quantify that. So utilizing this, we come up with a composite score, and each condition gets its own equilibrium score, 0 to 100% equilibrium. 0, a person's falling, 100% is that they're standing completely still. It's almost physiologically, humanly impossible to have 100% equilibrium on any of these conditions. We are constantly moving. As you can see, I'm constantly moving. I'm not pacing, not quite. But we all are moving. We think that we're standing here completely still, but there's always a little bit of movement. So where it becomes pathological is where if we cannot stand still and we start to lose the balance and we get out of our limits of stability, we are able to register that. So these 6 conditions apply, eyes open, eyes closed. And what we say as far as sway reference is that the platform that they're on, it's a force plate. It registers the amount of pressure when one moves in space standing still. And standing there, there's a pivot point that is not like a rocker board or a tilt board underneath. It's actually mimicking at the ankle joint the sway movement. It's actually kind of almost like a scooping motion. And sway reference means that if a person is in one of the conditions that the platform is able to move, is that as long as they move, the platform will move with them at the exact same degrees per second of movement that the person is. So during the assessment of the sensory organization test, they have no idea that that platform is moving unless they can, they have no idea that it's moving, but if they're visually able to register that they're moving, they can correct that balance. But if they really rely on their somatosensory system feedback from the legs, that orientation, they're going to go right over. They have no idea that they're falling because this is not perturbating them purposely. We can do that for training. We can move them specifically and give them perturbations. But for the SOT test, that's redundant, SOT, it is just referencing them. So as long as they're moving, it'll move with them. And then the visual surround is able to move as well. So in that last condition, a person is standing in a harness for safety, eyes open. You're thinking, oh, good. Well, eyes open, that's pretty easy. Last condition is the surround, which incorporates peripheral vision. So you're in here, and all you see is the half closet. The peripheral and your surface is able to move. As long as you move, it'll move with you. So the whole closet and the platform can move. So what system do you think that we're trying to tease out if the patient or participant is able to use for orientation to, where they are in space? What sensory system? Vestibular. Because now the visual surround is moving with them as long as they move. And the somatosensory system is moving with you. So if a person cannot integrate, utilize the inner ears, they have no idea. They will lose it immediately. So that's how we kind of tease it out through those conditions. So just some 2 variables combined, looking at the complaint of fatigue versus the SOT. Highly correlated, even in the subscales, very correlated, statistically significant. Okay, that's a good start. Teasing this out into the different conditions is what I was really interested in, because the overall score is one thing, but where along this paradigm spectrum of the conditions, because it becomes more dynamic as the conditions go up, where are they having more difficulties? So this trajectory of downward postural control and stability is a normal trajectory. It's just a little bit lower than persons without MS, because all these individuals were persons with MS. Then what I did was superimposed in corresponding association with fatigue. What I suspected is that in the simple, more simple static posturography, where it was eyes open, eyes closed, nothing moving, there was no association. That's where most of the study stopped. But by taking it to the next level, the relationships got much higher statistically and really clinically. When you're looking at R values, which is a correlational association values, in the 70s for a physical performance test, that's really, really clinically high. So that's a high correlation, but not until the conditions get more challenging in the ability to utilize vision, somatosensory, and vestibular system for integration. So then taken to the next level, what we know about the brain is that there's two areas of the central nervous system that are primary sensory integrators of those external sensory inputs, which is cerebellum and brainstem. Brainstem is primary because it really holds the nuclei, which includes the vestibular nuclei. The cerebellum, for coordination overall, it's kind of a secondary component for a lot of this integration. And the prevalence of involvement it has been estimated to be 70% or higher. And I believe that's and it's like, whoa, wait a minute, most of the MRIs are not going to be bringing that up. When we first wrote our current study trial, which was probably about 5 years ago, the way we had it set up, and I'll talk about it briefly in work in progress, is that we are analyzing based on strata, based on involvement in cerebellum, brainstem versus non-involvement, and trying to get equal people in the study with MS, those with and without involvement in these areas. We loaded up that first strata because it was way easier to find people with involvement. With the advancement of technology and MRI scans and reading, we are discovering that the involvement of these areas are much more earlier in the process of MS than we thought, and then we had to scramble to get the other strata and stop recruiting patients with involvement because we had so many of them. We were eventually able to find people without involvement in those areas, but it just kind of like says, yes, I believe this number is probably pretty correct, that even in early MS diagnoses, there's involvement in these areas. So this becomes even more important to get early involvement in some of the treatment strategies that I have that we can hone in on trying to improve the integration system, maybe possibly with neuroplasticity, possibly. So what I did was I broke it up into the functional systems of the EDSS and having the sensory pyramidal, cerebellum, brainstem separated, and then those that had combined involvement, and looked at first the fatigue and looked at was there a statistical difference in the amount of fatigue in those with involvement in sensory component, sensory loss, and those without. So as we go through here, we have not found anything until we get to having both cerebellar and brainstem involvement that we saw a comparison difference between fatigue, higher fatigue, lower fatigue in those individuals that did not have involvement in those areas versus those that did. Then looking at the overall balance in stability and balance, increased balance, less balance. So those with involvement in brainstem, those with brainstem and cerebellar had lower postural control. So intuitively, overall, that was what we were looking for. So that's actually what we're looking at in the current study too, is to see if by intervening with intervention that is trying to improve the integration and improve postural control, is it more beneficial for those with involvement versus those without involvement of those brain areas and regions. So it's supported by this research. So the integration network, it starts with the input, again, visual, somatosensory, and vestibular system. The central sensory integration, again, is primarily the cerebellum and brainstem regions. And then the reflex that comes out. So it's an actual reflex. It's not a cerebral control, central command. It's a reflex that comes out. So there's three primary reflexes that come out of this. The vestibular ocular reflex is the primary when we talk about visual stability. Visual stability and fixation is a problem in persons with MS and highly prevalent and has been related to advanced disability overall and has been linked to impaired posture and, control and fatigue in patients with MS as well. That somewhat relates into dizziness and making sure that we have a good definition of dizziness. Dizziness is the overall umbrella term. And underneath that is our vertigo, our postural component as well, unstable postural control. So when you're interviewing and talking with your patients and you're asking, do you have dizziness, you need to delve into that. Are you relating your dizziness to something that is more of a spinning, a vertigo? Because we have our questionnaires of dizziness handicap inventory and other Likert scales that we say how high is your dizziness, low is your dizziness. But we have to make sure that we are very clear when we are asking our patients what that dizziness is and what actually provokes that dizziness. So vertigo in patients with MS is prevalent, but most of that prevalence is due to what is happening in the regular population. So most of the vertigo that we find, unless it's an acute exacerbation in MS that hits either the root entry point for the cranial nerve, eighth cranial nerve, or at the actual nuclei itself, it's usually going to be benign positional vertigo, which needs to be screened out to make sure that this is not a peripheral end organ problem versus a central integration problem. So that's sort of a caveat for the clinicians. So the other arc reflex that comes out is the overall head stability. I'm not going to get into this one, but just kind of a understanding that there's a separate vestibular colic, which is the head stabilizer reflex that comes out of that network. But then also the vestibular spinal reflex, which is what keeps us upright in response. So that's our postural control, and primarily is an extensor pattern, because if it was more of a flexor pattern, assistance, you'd be down. So with integration and output, this vestibular spinal reflex allows patients to be upright until they can register what to do more cerebrally. And obviously, any dysfunction that is external from the end organs, which would be visual impairment, that is not from the reflex arc, it has to be taken into consideration for a poor central integration process, as well as the high prevalence of somatosensory loss, vibrational sensation, light touch, deep pressure, and positional sensation are all something that obviously we have to screen to make sure that we have a good picture of what might be causing the imbalance in our patients with MS. And then obviously any of the impairment of the end organ, and I'm talking about the semicircular canal, the utricle and saccule of the vestibular end organ. So to go through this again and very quickly is that any dysfunction that essentially, obviously in patients with MS is more of a central component, is that any impairment is going to disrupt the homeostasis of upright postural control. That leads to possibly falls, that leads to decreased participation in social activities, as well as work and other things, because of possibly that poor integration of the sensory systems. The proximal outcomes primarily is the impaired postural stability, impaired visual stability, and then also dizziness as a symptom. The distal component that I was really interested in my early research is what happens from all of this impairment of these functional components and the symptom of dizziness. Could this be a small link in a factor that might be causing some of the symptomatic fatigue in patients with MS? If we can screen for impairment of integration and the postural control, and then knowing that it's related, the postural control dynamically is related to fatigue, is it possible that, yes, the distal outcome for these individuals might be the perception of fatigue? So the next step was design a treatment that could improve postural control as well as the symptomatic fatigue. So the BEAMS program is something I designed and put to the test in a pilot study a few years ago. It incorporates the eye movements, which is saccadic eye movements, smooth pursuit or tracking, and vestibular ocular reflex, which is more of a functionality of the VOR. And then various balance tasks. So I'm going to quickly go through this. A lot of these tasks are something that we've done for years, for decades in rehab, but I packaged it more so in a program that is semi-structured. It could be a la carte in a way, However, you want to try to get the patient to experience as many challenges in somatosensory input, challenges in absence of visual stability. How do you create absence of vision when you're training postural control? Close eyes. Perfect. So you close your eyes, that's absent. However, we don't walk around with our eyes closed very often. So visual stimulus and confusion, so with head movements and maybe even tracking, that can cause some visual disturbance. So that's the challenging of visual system versus absence. So you want to do both of those. And then stimulating the vestibular system, because we cannot take the vestibular, you don't want to take them out. And then say, okay, now try to balance with a complete absence of vestibular component. Now put them back in. So simple conditioning goes back to Pavlov. Give and take a stimulus for a response. That's what we're doing here, trying to condition the theory we're postulating is you're conditioning that central sensory integration components for an output of improving balance, dynamic balance, possibly improving visual stability, that improves dizziness, and then the distal component of improving symptomatic fatigue. What they look like is obviously for the track, I don't like to put videos in my talks because they inevitably go to the wayside. They don't work very well. So this is looking at tracking. What my student is doing is just, she's standing and tracking. You can start with this in sitting, progress to standing, and then progress to doing it on different conditions of somatosensory input, and I'll go through that. So it's kind of like a mixing and matching, again, a la carte for your patients, which this is a low-tech approach, which I prescribe this with handouts for my patients to do at home, which is key, because if they have to come in and only get your treatments in the clinic, we've got a problem. So if they can take this and run with it, it's going to be more beneficial for them and will stick better. Saccadic eye movements, so you have to have 2 points, and then head movements, vestibular ocular reflex, both in the yaw position and pitch position, trying to train that. We do not know at this point if we're doing anything for improving vestibular stability, visual stability, but hopefully in our current study that we have some early evidence of that possibility. So some of the static surface positions, so feet apart, feet together, semi-tandem, full tandem. Compliant surface, so I use this for multi-directional instability. You want a foam that they cannot feel or bottom out and feel the ground underneath. That defeats the purpose. We are trying to mimic some of the unstable surfaces that patients with MS usually say, I'm not going across that grass or that sand, I'm going to take the long way around on more of a stable surface. And that becomes a problem both mentally and physically if they have to exert more energy to go around and not take the straight line. So if we can try to improve unstable surfaces reactions in multi-directions, that'd be great. And then multi-directions on a trampoline, it's like, whoa, you get your patients on trampolines? Yes, because now this becomes more dynamic, much more dynamic. So when a patient with MS or any patient is starting to load the spring on one end, it loads that energy. So then I use this for more fine tuning. So we talk a lot about fine motor control in fingers, but there's a lot of fine motor that happens at the front line of gaining our stability. Like I told you, we don't stand completely still. That's because we have fine motor components going on very early in the stability. However, with patients, there's a lot of big, grandiose movements. Hip strategies, maybe really strong ankle strategies, instability, and they can get away with that when there's a stable surface. Big movements, you can take steps out, but when we talk about loading and then you get sprung, you start to learn. So these patients need to experience the error, so not air, but error in their stability. If they don't experience that, they cannot learn it. So you need to tax the patients as enough in a safe way. Obviously, you don't want the patients falling every time you get them on a trampoline, but experience that so that they can start to then be a little bit more economical in their stability. And that's, to me, kind of the theory of how symptomatic fatigue and improvements of this grandiose big movements into a little bit more finer economical stability translates into possibly less symptomatic fatigue. Bidirectional instability, so obviously there's slanted surfaces that we have to try to mimic in the clinic and at home, downward slope and also to the side. And head movements, so head movements, what does the head movements do? They stimulate the vestibular system. With eyes open, eyes closed, it's a little bit different because if you have eyes closed, there's no visual confliction. But with eyes open and you want them turning the head and looking for traffic side to side, look for birds and looking for worms up and down, you're getting that stimulus to the vestibular system, but with eyes open you're also getting a confliction of visual input. So there's reasons why we want to do this. Number one, we're trying to stimulate the vestibular system so the brain in the patient with MS can learn how to integrate that movement. Because there's a lot of head movements that we do. Look down the hallway before we look, go across the street, and making sure that we don't get hit by a car as we walk across the street. If you cannot do that, there's a big limitation. A lot of the falls that occur in patients with MS is occurring because maybe quick head movements or quick body movements in rotations. I was in a conference that was made up of professionals, both of all types of researchers and clinicians, and experts in balance in MS. And there was a statement by a lecturer that said that we know that our patients with MS have no problems turning their head and balancing and walking at the same time. And my jaw just dropped, and I kept my hand down, and we talked later. But I was completely shocked because head movements is a big component of the BEAMS program. So then, again, kind of a la carte in this. So moving the head in the same direction of the bidirectional movements can be quite stimulating and challenging. And then breaking down, decreasing some of the degrees of freedom, some of the motor control components in a strided out position, kind of like in ambulation, and getting more of a torsional rotation as we would in walking. But creating this motion, both arms up, both arms, and rotation creates movement that they have to control along with the head movements. And then hand-eye coordination, ball tossing. And then additional components on the trampoline that increases stimulation of the vestibular system as well. And then the on-command walking tasks that are incorporated into the BEAMS program, where now we start to move in space rather than standing in space. With this, there's a whole bunch of head movements with walking, sudden stops. So what I try to do with my patients and in the research is to try to mimic what the environment is doing to us. You cannot pre-plan. Our patients think that they can go out every day and say, I will completely be able to control everything around me. Ain't happening. So we try to mimic maybe sudden stops, starts, turns that they do not pre-plan for. It's a reaction that they need to try to learn, relearn, and or at the front end of that curve is to make sure that this does not become a problem down the road. Because if left untreated, because we do not have a cure for MS, we know that it's the highly likelihood of it progressing to a problem is there. So this should be early treatment. So this was put to the test in a 3-group study. The experimental group received the BEAMS program. The exercise control group was an active control to decrease any attention bias in the pilot. They did a exercise ergometer and stretching program, and the control group was a true control group, nothing. So over 6 weeks of time of training, of supervised training, 2 times a week, so 12 sessions. The improvement in balance, which was the SOT, dynamic postural control, it looked like each of the groups improved somewhat because there's a learning curve in that SOT as well. However, at baseline we did 2, so my standard approach in research sometimes in clinic is to get a good baseline, you need 2 measures. So we do a 2-measurement baseline to factor that out, take a weighted average at the beginning. So we tried to factor out any learning curve at the baseline, and then some of this is This is not really clinically important improvements in 5% of equilibrium, not that important, both in control and experimental group. But the Beams program improved almost by 20% in their equilibrium, which is a clinically and statistically significant improvement. And then after 4 weeks of just doing the home program of the Beams and then doing their stretching program in the exercise control and doing nothing for 4 weeks, the overall standard of improvements were held up during self-administration. So no more supervised. So there's a trend there that says if they continue doing their exercises on their own, they can maintain that stability that they gain from the supervised. In the current study, we're taking that out an additional 8 weeks instead of just the 6 weeks to see if that dosage can improve that trajectory a little bit higher, so that once they get to here and they continue their exercise program on their own, that they're at a higher rate for balance control. This was also the case for, obviously, we want to see a decline in fatigue. So decline in fatigue was also matched. This is as far as really any intervention in MS, but more specifically for exercise, any rehab approach for trying to decrease symptomatic fatigue in MS. There was a systematic review that just came out, and we were #2 in the amount of actual delta change in fatigue, symptomatic fatigue, as far as the systematic review showing that we had the second highest improvement in the Beams program for symptomatic fatigue improvement. So 22% improvement, points improvements in the MFIS is really statistically and clinically significant. Also, the standard of that improvement held within the baseline follow-up phase. So then dizziness also improved by 18, almost 19% improvement in dizziness as well. So kind of a trifecta improvement in the Beams in that pilot study. We then broke it out into a very, very small, this is something that we could not report in a paper, but was helpful in, obviously, in grant writing, is to show some early evidence that, again, persons with brainstem cerebellar involvement versus those without that participated in that Beams program, you can see that for those that had involvement, started out a little bit lower, that's intuitively correct, started off lower in their balance. The other group that within the Beams program started higher in their balance, and their improvements were not as large. So the delta change in those without was 12-point improvements in postural control, and those with was almost twice that much. And that difference is statistically significant. So that led to our current study that is now looking at stratifying those with involvement and those without, and doing a larger study on that. Okay, so now just bringing this more to clinically and the determinants of identifying persons with MS who might benefit the most from the Beams program, because my ultimate goal is to make sure that we're very prescriptive in our therapies. And this is one way that I can kind of give you some guidance. And the handouts you'll have will have this all for you, of course. So obviously symptomatic, subjective history, and then our outcome measures as well. Our current knowledge is that based on disability level, in the pilot study, we pretty much stopped before the need for assisted device. In the current larger study, we advanced that into higher disability involvement so that we maybe can be a little bit more generalizable to early possible cane use and or use of cane for shorter distances. So we're looking at individuals in EDSS up to 6 now. But our current knowledge is at that point. Symptomatic history is huge. So most of my examination, my early examination, is involving trying to solve these puzzles. So if I go down the route of identifying the person with MS might have risk of falls, risk of gait impairment or show gait impairment, am I looking at someone that might have impaired imbalance due to eye movement, symptomatic fatigue, and dizziness? So we have to measure those, but also talk to our patients about that. circumstantial evidence, but contextual factors leading to the imbalance. Is it because of uneven surfaces? Or is it because when you turn your head, you lose your balance and you fall? Are we looking at sensory stimulating environments and interruption and attention to tasks? So are they being challenged in multitasking? And then does that relate into falls and participation restrictions? So obviously we are better clinicians. We combine physical performance and patient-reported outcomes. So obviously I have to state that. And making sure that we're also analyzing at least what the clinical presentation and functionality of the VOR, the saccadic eye movements, and possible even vergence and symptom provocation when we're assessing that. So in my lab, we're able to do the functionality of vestibular ocular reflex with the Gait stabilization test and the DVAT, which is a dynamic visual acuity test, which is not diagnosing it. So it's not diagnosing vestibular ocular reflex dysfunction, but it's more the functionality. Are you able to maintain a fairly stable visual acuity when moving your head? We will degrade in the Snelling chart when we look at an eye chart. We normally degrade by about 1 or 2 lines when we do a yaw and possibly also pitch movement. So as you move, you degrade a bit. Where it becomes more pathological is you start to degrade in your visual acuity even more lines when you're doing this head movement. The technology that we have does not look at a Snelling chart, but it does an optotype that shows up in different orientations and speeds coming up and sizes. So it really hones in on trying to quantify visual stability during head movements. Now I say the modified CAT-SIB, but also the full CAT-SIB includes the foam and dome, so it tries to get to that SOT, but sometimes it's really hard to design a dome. So the modified CAT-SIB has been validated in patients other than MS, unfortunately, but it's validated as an actual test of postural control. This is time for each condition is upwards of 30 seconds. It's a very straightforward quantification of ability to stand with eyes open, eyes closed on firm and foam surface. This is a good way of understanding a patient with MS might benefit from the BEAMS program, having difficulties orienting themselves because of confliction or absence of sensory input. Dynamic gait index, I've given you some of the cutoff scores and utilizing the gait index for an actual determination of fall risk. Berg balance is useful as well, giving you the cutoffs for that as well. And then ABC, this is the fear, possible fear of falling component, again, is also something that could be sensitive and specific for fall risk in patients with MS. Dizziness handicap inventory, obviously in our early studies that it's also responsive to the BEAMS program. The modified fatigue impact scale, also responsive with the BEAMS program in identifying and also giving you some of the minimal detectable change studies. And obviously the one thing about the caveat for these reliability and change scores is that you have to make sure that you understand that this is the change score for each one of these populations in each one of these studies. So it's not always something that we can say that we need to bank our improvements in the MFIS, that the only way that you're actually going to get any significant improvement if you get 20 points or more reduction in your fatigue. This is actually just based on this study, so that's a caveat on some of these detectable changes scores. And then you have to understand that there are some side effects, just like any possible drug, there's side effects. With the BEAMS program, there is a fairly long list, but this is completely normal and something that as clinicians we want to see. That means that the BEAMS program is probably something that they for sure have to be participating in, because if they're having these symptoms and they're provoking this with the training, it means that they're having problems with it, and they need to try to condition this. However, early on when I integrated this into the clinic, I wasn't giving them this I was not educating my patients, and guess what? I lost a whole bunch of people to follow up, and I was like, why are they not coming back? because I wasn't telling them this is something that's this is happening. Because a lot of times patients want to come in like for pain. I want my pain to go down. I don't want my pain to go up and then down. With this, they need to be educated that you actually want some of this to go up before you can bring it down. So by challenging something that they usually either purposely or not purposely avoid throughout their days, is that we're challenging them now. And you're going to have some side effects, which is completely normal. So work in progress real quick on the BEAMS program is to try to hone in on, is it possible that we are seeing some central organization, neuroplasticity? Are we actually changing anything going on in the cerebellum and brainstem? So what we know about neuroplasticity is that training-induced central integration is really key. So what I'm thinking is that the BEAMS program is one of those treatments that could be the training or experience-related component that is needed for actual change in the central nervous system. So laundry list of, yeah, it's possible that we have spontaneous improvement in patients with MS just by overall time in the way the body heals. But that spontaneous improvement is never really reorganized well and not completely. So obviously we cannot rely on that with continued attacks and or progression of the MS. So this is my theory, is that by constraining certain sensory inputs, stimulating certain inputs, vestibular system, kind of taking away and giving, we're conditioning the central sensory integration components to get a better performance of those areas. So again, in our current study, we're looking at multiple components. Secondary outcomes is the visual stability, gait speed and fatigue, and also early self-related cognitive involvement. So if we see any movement on that meter of the cognition, because I'm thinking that it's possible by having less confusion throughout the day, dizziness and fatigue, could this be another factor of possible executive functioning, being able to attention to task? There's multitudes of domains of cognition. I'm not saying it's going to improve everything in cognition, but can we see if it is very prescriptive for certain components of conditions? So that'll be exciting if we see that. We're running data on that now. We're done with recruitment. This is broken down into brainstem cerebellar strata, non-brainstem cerebellar strata. These are obviously statistically comparative. And so we have a good starting point. Now we're running baseline data and running follow-up data too. So very soon, hoping by the end of this year that we'll have a couple of reports out on print. Other work in progress, technology-based quantification of fall risk, is that part of my grantee with the National MS Society is working on a pilot to determine head shake SOT. That is the head movement in yaw and pitch, and looking to see if the regular SOT, the head shake, or head movement, I hate to say head shake, they're not sitting there going blah, but head movements, are we able to determine fall risk better by this technology and the addition of head movements? Is that more predictive of falls in patients with MS than some of our standard clinical measures? So that's underway right now. We're about a third of the way through our sample that we need. Other components of abnormal gait is weakness, of course. So one of my studies looked at performance fatigability, looking at the peripheral component. So what we do know in the current research or prior research was mixed, that the central drive, because MS is a central nervous system problem, is that the central drive was not allowing continued repetitive contraction of muscles, and that's why there's the early fatigability, because it's the clinical dilemma of why, as a patient, and then also as a clinician, saying why after the 25-foot walk test, why after the 2-minute walk test, the patient starts off without a foot drag or a foot drop, and all of a sudden it starts to slap, and then after about 2 minutes we start to see the drag. What is happening? The MS is not getting worse during that time. What's happening in the periphery? So my colleague from Colorado State University and I looked at the possible peripheral component of glucose uptake in the muscles peripherally. Has really nothing to do with the central nervous system. So we use PET technology And so what we do here is we have obviously CT, so we have to, PET imaging is very messy. So when you look at a PET imaging just by itself, it looks like a glowing, colorful blob of ghost. It really doesn't tell you much. So you do need to do CT imaging to differentiate muscle groups and then superimpose that on top of each other to identify. This is a cross-section of a thigh of one of our patients. So I'm going to ask you a question pretty soon if you can identify, because we did a study, a pilot study on 15-minute walk test on a treadmill. Immediately at the start of that 15-minute walk test, we injected the nuclear isotope for PET imaging. The FDG that uptakes in the muscles binds to glucose, and we were able to look at muscle glucose uptake in muscles during walking. And we did that in healthy controls and persons with MS. So I'm going to ask you a question, but I'm going to have Rob and anyone else from yesterday abstain from voting on this,
Okay. Yeah.
because Rob's an expert on this, so is everybody else. So this is an age, gender-matched individuals from the study. So this color means more uptake of glucose in the muscles. This color, which is pretty much black or blue, means less uptake of glucose in the muscles. From your left, right, which is the patient with MS? One of them is MS, one of them is not MS. Right is MS. Do we have more for right? Left? Oh, sure, you just want to be politically correct and vote on both sides. So it's left. And it was actually what we thought going in was that we were going to see possibly less glucose uptake. And glucose uptake would give us an idea of muscle activity. So we thought, well, patients with MS have weakness, there's less muscle activity, probably less glucose uptake. Completely opposite. So again, there's discoveries that we happen upon. So yes, patient with MS using a ton of glucose, using a ton of energy. And this is something then I look back and I was like, well, clinically, yes, that completely makes sense. And then also, this is the patient's weaker side, because there's usually a unilateral component to it. And look at that hip that's compensating for the left side as well. So the hip is working harder. The lower extremity is working tons, and we should not. As we are moving through space, we should not, unless we're walking quick or running, this is self-selected speed, we should not be working our lower extremities that much. So they are pushing off to get going, and that's not economically in their advantage. Yes?
Are you like excluding people with hip arthritis or bunion deformities?
No orthopedic components other than would it limit you from walking. If you can walk, you were in the study, and without assisted device for patients with MS. So yeah, there was no real restrictions in that. So yes, there could be something that they were relating, but there was none of them reported pain with no antalgic pain or anything like that.
Samples, serum glucose levels?
No, that's our next step. So then we have to, this is our first step in the line of this research. We have to figure out what's going on. Not only that is, yeah, there's no problem uptake. There's no problem getting the glucose up. But what do we know about energy going into anything? Energy going into a factory. You put coal into the factory, what comes out? Yeah, waste, byproducts. Same thing with glucose. All that metabolism has a byproduct, which is usually lactic acid, which is usually causing what to muscles? Fatigue. So this is also clinically relevant immediately. I know this is early evidence about this, and maybe our next studies don't prove it as much, but I can tell you right now, clinically relevant is a recent report that went out about the intermittent walking and how beneficial it is to make sure that we are having our persons with MS, make sure that they're not trying to walk for a mile long, and even though we're pushing for more activity, making sure that it's more in intervals. Because in that report, symptomatic fatigue was improved. Also, muscle performance was improved when it was chunked out. Let's say 2 minutes of walking, 5 minutes of walking. I've suggested that for years because it's so beneficial, because then the amount of accumulation of fatigue doesn't occur at the end of 15 minutes of walking. You can head that off, allow for recovery, get back up, because you, as far as physical activity, can accumulate time of exercise overall during the day. A person with MS has to understand it does not have to be 30, 45 minutes or an hour all at one chunk. That was the 20 years ago where we got ourselves in trouble about exercise in MS. Like, don't do it. You're going to get fatigued. But if we do it correctly and we abide by the rules of the body and what MS brings to the table, we can prescribe this better. So it's possible that we're seeing that accumulation, and by having intermittent rest periods. Rest period anywhere from 30 seconds to 2 minutes tops. We're not talking about a nap in between your walk periods. So if you're walking in the park and they love to walk in the park, say you make sure that you got some benches that you can sit down. You have to rest the muscles, not stand and rest. Because standing is that much harder for muscles. So it's got to be an actual reduction of any muscle activity for at least 30 seconds to a minute or two is what I found to be very clinically important. And we might be seeing that it might be allowing them to, quote unquote, flush out some of that byproduct.
One question.
Uh-huh.
On the previous slide, are there implications of moving the glucose consumption from the chest and abdomen and pelvis to the
So moving,
on the
Uh-huh.
right view? We're seeing a lot of glucose consumption in what I'm assuming is the upper abdomen and the pelvis.
Mhm.
And on the left one, we're not seeing that. It's all moved to the hip and the lower.
oh, right. No, right. So that's something that we were thinking about. Is it also possibly a brain drain too? So, you know, is it that we're using so much down here? We don't know. That's where the serum glucose will help, you know, what's happening in the rest of the body. But your point is well taken, is that if we're using it all up for walking, where else is it being drained from? Is that kind of what you're...
Yeah, and on
yeah.
the brain view, on the right, you can see I think the brain stem, and on the left you can't.
Yeah, so that might be some just like imaging differences as well, because it's not a perfect, you know, brought over at this same level in a way. It's fairly a gross comparison, but even in the gross comparison, you can see the differences there. And this is obviously our biggest example differences. Not all of them were like this drastic, but this is one that's always nice. It's actually in the paper as well.
So Jeff, excuse me for a sec. So would that also speak to the fact that we need to strengthen the core more in people with MS?
Exactly. So, but also here, core muscles. So we also looked at the core muscles, and we also found the differences here too. So not as drastic, but an example here is that we have more activity on the weaker, on the stronger side, more activity in the trunk. Now what's great about PET imaging and doing it this way is that this is a way that we can get to muscle activity in the trunk, because some of our EMG, surface EMG stuff is very convoluted in what we're looking at. And it's hard to look at activity. So we were able to look at core activity, and it bodes to, should we be concentrating on the core? And most definitely. So it really supports why we should. And especially the lateral trunk stability. So getting people to do more plank activities would be very beneficial. Some more Pilates and yoga positionings. And then finishing up here, we're also looking at augmentation of performance, obviously with our electrical stimulation. We're doing a study for that as well, and that's supported by the the NIH. And then negative prognostic factors, what we do know is one of them is being male. Being male is a more advancement of disability. They tend to have more physical disability overall, and it's fairly unknown why. So one of the areas that I want to look at, in that sample too, was to look at the actual brain and the cognitive motor brain centers. So we looked at the cerebellum, the thalamus, and focused in on those, and the frontal lobe and cortices. And we looked to see if there was any differences in the males with MS versus females with MS. And we looked at that and just recently published the work that did see, and this shows, it's not a comparison like you saw before. This now is more yellow versus red, and almost white indicates where in the brain there was a significant difference between glucose uptake, brain activity in patients with MS, male versus female. And it was definitely that females had more activity in the brain in a very simple walk task. What we think is simple. So, however, it's a very, very complex activity. We think it's simple because we learn it early, but in the thalamus and in the cerebellum and in the frontal lobes, there was a significant difference between patients with MS in male versus female. So women out there, don't get a big head now. I hate giving this last little slide because then you get overconfident. No, I'm just kidding. So this is just early evidence that there might be something that, and these are individuals with very low disability, early onset of MS really, and there's actual differences, male versus female. Possibly some indication in why we're seeing this advancement. So generally, final talks is that this is just one aspect of care for patients with MS, knowing that there's multiple tools in our toolbox. So hopefully this gave you some indication of a strong tool and tools that might be out there in the future for you as clinicians to move forward with. So I just want to acknowledge, obviously, all the participants and volunteers that participated in my research, and my collaborators along, with the National MS Society and my MS Center, and also my girls would love to thank you as well. Thank you.